going to be very practical CDF guide. And you guys have done these, but this is I'm gonna hit some higher level stuff. Get into the weeds as well on the technical aspects of doing ACDF, things maybe you haven't seen yet. Should be on, ready to roll. So just sample case, young guy with you can see what is a spondylotic spine, disc herniation, little cord impact, some weakness and symptoms that have gone on for 8 weeks. So this is the typical example of somebody who's probably going to be a good candidate for an ACDF. And, importantly, nowadays maybe a disc replacement, but when you have a lot of disc collapse, as you see there, probably not a great candidate for a disc replacement. So lots of options, but ACDF is where we're headed today. There's lots of ways to set up. You guys, I'm sure, have had your prior mentors do it in various ways. You can see up at the top, Curlex that's sort of wrapped around the wrist, a web roll under that. And so you can use that for traction. Some people like to set that up at a time. Some people like to put tape on the shoulders. There's actually devices that press the shoulders down mechanically, and you can see this more expensive setup on the bottom. So there's lots of ways to skin a cat. Traction's not critical, but it can be helpful at certain parts of the case. So if you don't like to wear lead, you probably will want to have something available to place some traction on the shoulders or the arms so that you can see the lower levels. That becomes even more important when you're doing disc replacements because you really have to see those well and make sure they're set. So just plan accordingly. If you have the Curlex on the wrist, you got to have somebody kind of pull on them. You're obviously scrubbed in. That's how I did it when I was a resident. But I've actually migrated to not using anything. And with ACDFs, most of the time I can see it with the better C-arms that we have now. So it's not really an issue anymore. And if I really want to see it well, I'll pull the shoulders down briefly. And I've kind of leaned away from constant traction just because I think there's probably something to traction on the nerve roots on a constant basis that I don't like, both posterior and anterior. So keep that in mind. Traction's also used by some people, and you can have them on the horseshoe. You can have them on a regular table like this. Stephen uses a flat OSI table. So it really just depends on what you want table setup wise, but you can still apply traction regardless. I don't typically do that, but it can be useful. Say if you have somebody with real soft bone and in terms of distracting the disc space and not having to apply as much load perhaps on the Caspar pins. So if you have real fragile bone, maybe you think about doing that with with trauma, obviously more critical. If you have a deformity that you're trying to correct a little bit, that can also be helpful in kind of pulling them out of some of the kyphosis if there's a little bit of flexibility to it. With disc replacement position in particular, and some people do this even with ACDFs, you see the tape over the head, that kind of keeps the head from rolling. And with CDRs, because it's so sensitive to positioning the implant, it's ideal to have the head really stationary and not roll on you in the middle of the case, which can malrotate or derotate the vertebrae relative to one another. You can see how taped is from shoulders down to the feet. So that's that constant traction that I tend not to like as much. Extending the neck, obviously you have to be a bit careful with that. But you can do it in different ways. Some people like to put a towel or something to lift the thorax up. So you could put something down longitudinally below the thoracic spine. Some people like to put it across in a horizontal fashion, sort of from shoulder blade to shoulder blade. The point is you're trying to create a little bit of a suspension for the head to fall off. When you're doing disc replacements in particular, there's some guidance to put a rolled towel behind the neck to provide a backstop and to create a lordotic nature to the cervical spine. And then depending on the table you use, you can't do it with a flat OSI, but with a regular table, For instance, if you're doing a bit of a kyphotic spine over multiple levels, you can have the anesthesiologist involved and have them drop the heads after you do certain levels or after you do a level or two, and you start creating lordosis because the neck will accommodate that, and you can help yourself with the subsequent levels on a multi-level recon. Imaging. There are many ways to skin that cat. Just from an efficiency perspective, it's nice to have the C-arm in the field while you're working rather than having to bring it in after you've started. So typically I'll have it set up this way where the C-arm's under in a lateral position. It's slid north where the anesthesiologist is. And then we just bring it down under the drapes for our lateral shots. It's rare that you need an A to P shot in the middle of the case other than disc replacement. That's the one time where I'll still have it in this position, but you have to go up and down a bit more to make sure that you're well centered. All right. Any questions about setup? Okay, incision strategies. You absolutely can take x-rays to do this. Many people do. I had the fortune of writing chapters on it, doing a lot of anatomic studies on the cervical spine. So I almost always just use anatomic features of the neck to drive the incision location. Choosing the type of incision now is even more, a little less prescriptive than it used to be. With a 5-level or more, and even some 5 levels now we can do with just a transverse incision, but generally speaking, certainly as you're getting your feet wet, if you're north of 3 or 4 levels, you're going to start leaning towards it, what we call an extensile incision on the left. And that's really just along the SCM border. With segmental plating, segmental reconstruction, which we do a bit more here, meaning an individual plate and screw and cage at each level, it actually is tenable to do 4 or 5 levels to a single transverse incision. And you have to be thoughtful about how you do that, but you're essentially picking an incision location that's generally a little farther towards the caudal end of that extent of reconstruction, and then starting your reconstruction at the cephalad aspect. So let's say it's a 3 to 7, you'd put an incision down near C6 or closer to 5-6 to C6, and then start the ACDFs at C3-4. And then you work your way down, pushing the head away.
Yeah.
But when you look back in there at the end, you've actually lengthened the neck sometimes an inch. But typically you try to restrain it to 1.5 centimeters to a centimeter. But when you look in your transverse incision wound at the end, you'll see it's very hard to get to the top plate because you actually incrementally push that upper level away. Anyway, it's a feasibility of allowing a long reconstruction that we used to not be able to do. And if you use a long plate, you can't really do. You push the top end away by the time putting the plate on. With corpectomies that are long, you tend to need to do the extensile incision because of that need to see a lot, to be putting long things through the incision, and that includes the plate. Questions about that? Make sense?
Yeah.
A little. Sometimes it's hard to get your arms around it until you see it work. But you'll see in lateral surgery, we do the same thing with deformities or multi-levels. We'll start at the top and push the spine away. And then that allows you to go through a single incision that's a little lower.
I guess if you're doing like a big reconstruction through a transverse incision, do you have, like, what's the work around the omohyoid? Do you have to like kind of go?
Great question.
Yeah.
So you have 2 options. You can sack it, and typically I'll repair it if I sack it, but I usually preserve it. And so you'll usually find the omohyoid around C6, which means if you're working from, say you're doing a 3 to 7, 6-7 can be hard to get to by retracting the omohyoid. Mm-hmm. So if I can't retract it readily, then I'll reposition the cast bar pins below it. So I'll take the retractors out as I go from 5-6 to 6-7, and then reposition it below the omohyoid rather than working above it.
Got it.
Some people just sack it and leave it fly, but I always have a hard time doing that with muscle anatomy that we don't understand fully.
Yeah.
There's a function probably that we haven't really gotten our arms around. So I like to repair it, even if you have to sack it for the purpose of getting to the surgery. All right, so this is more about how you place your incision, and really just knowing the landmarks. You'll get some fat necks that are really hard to fill things, but it's pretty common you can fill something. Thyroid cartilage, the cricoid can be felt most of the time, and those are your go-tos. Cricoid you should think of as around C6. You can sometimes feel the carotid tubercle, but know those anatomic landmarks, and then you can really nicely design your incision location off of that. So that's the first thing you feel. Know what those represent in terms of vertebral anatomy levels, and then I look at the skin secondarily. So if I'm wanting to get to C5-6, I'll look for the cricoid cartilage, and then look for a skin crease that approximates that, and try to put my incision in a neck crease. So when it heals up, it's cosmetically appealing. And then I already mentioned about the multi-level. So cheat a little bit lower on the multi-levels. In terms of approach, after you get through the skin, different options. We have traditionally transected the platysma in a horizontal fashion or across the muscle fibers. I still don't totally understand that, so I'll often longitudinally split them. It definitely is easier to repair a platysma if you transversely cut it. It's easier to find the fascia. So that may actually be the primary reason that it's been this legacy move, but you don't have to do that. So especially for a longer recon, I'll just split the fibers and bring them back together at the end rather than transect them. Once you're through that, it's nice to undermine, create a little bit of a cavity underneath the platysma, and that allows you to start seeing the anatomy, particularly the sternocleidomastoid. And it's, I think early on, it's most common for people to feel more comfortable going laterally towards the SCM because it's less dangerous than the goose and the carotid sheath. But it can be both bloody and more challenging to find your way once you get into the SCM. So try to stay out of the SCM fascia and use the fascia of the SCM as your guide, just to sort of move medial to that. As you work under the platysma, use the retractors a little bit to lift up, and you'll create a little bit of a plane differentiator by doing that. And you know that, but you doing many approaches, it's the same thing. If you lift up on the skin or the superficial tissues a little bit, it starts creating a little more three-dimensional clarity below that, and that'll help you find your way. And you can use your finger as well, but people's fascial planes differ quite substantially. Some are very rigid, some are supple, and you can kind of move through it easily, but lifting up will help you. Once you do that, and try to identify the SCM and its fascia, then start palpating for the carotid sheath, which is obvious. How you move through that area is completely up to you, and you're going to see lots of different ways to do it. Use Kittners. You can use your finger. Some people literally just use their finger to dissect through that stuff, and that can be more or less easy based on their fascial rigidity. And then some people use the scissors. So you'll have to find your happy place in that regard, and you probably need to switch up here and there. But if you do a revision, you may look for those same planes, but they'll be a little bit scarred, and then you'll probably be leaning towards more scissors and Kittners than finger dissection, which will be much harder. But know those primary structures, the carotid sheath, and palpating at the fascia of the SCM, and you'll go medial to the SCM to find that carotid sheath. The other thing to keep in mind about that approach is where you find things varies depending on what level you're at. If you're upper cervical, you're working much more laterally to get to the SCM, and then have to come much more medial. If you're down to 6-7-7-1, you feel sometimes somewhat uncomfortably medial or midline to get to those same structures. So be ready to adjust with that. Once you're down to the prevertebral fascia, I assume everybody does this now, but it wasn't so when I trained. Everybody was sticking needles in the disc spaces. So hopefully that's an issue of yesteryear. But use something that's not penetrating to the disc to identify that you're hopefully at the right level. Because if you're not, you don't want to injure it. All right, once you're down, this is what you're going to see on the right. This is obviously a cadaver, but I put that up there just to help you understand how to identify midline without taking X-ray. First, you're going to choose the length of the retractor blades, and there's a little color stick for that for most of the retractor systems. That's your first. Basically, as soon as you get through, you identify the front of the spine. You can do that so they can prepare the right blade length on the back table. And then you want to identify the longest coli, which you see here on the right side of the screen. In that picture, bring my cursor up there. I like, whether it's a disc replacement or an ACDF, to really identify the midline by finding that midpoint between the longest coli, which varies. You know, if you're up at C3, 4, like this spot right there, it is narrower. But regardless, as you move down, generally speaking, that longest, I give you sort of this nice bisection. You find that midpoint between the two, and then you can mark with your bovie above and below the disc space. So let's say, sorry guys, it's not working on here. Let's say you're going to do 4, 5 here. I would bovie mark the vertebral body right here, and then the vertebral body right here. Oops. And that way you know where your midline is from there on out. And then subperiosteally dissect cephalad and caudate to those 2 marks and up to the lateral aspects of that disc space and elevate the longest coli off. So that is super helpful with disc replacements because you need to be right in the middle. I still check those with X-ray, but it gives you a good starting point. With ACDFs, which are much less sensitive, it's all you need. You're going to be right on target. There will be cases where people have dish, a huge amount of bony irregularities that push the longus around and may disturb that symmetry. So if you have that extreme spondylosis or ankylosing kind of conditions, you have to adjust your plan a little bit and be a bit more thoughtful, and then go to deeper anatomy to get a better sense of the midline, and use the uncus as an example on either side. All right. So what lies laterally to this that you have to be careful of? Yeah, right. So one of that can be injured by not knowing where you are, coming down lateral to the carotid sheath. It can happen by retraction over the top of the longus, where your blades are actually making contact or compressing or injuring the sympathetic chain. So this move to elevate the longest coli helps prevent that, because you can seat your long retractors and the teeth or the blade part underneath the longus. And that gives you a nice restraint from creating injury laterally to those. Does that make sense? So elevate those longest coli first, and then place your retractors medial lateral, and then you can put Caspar pins. The Caspar pins, in general, if you're sort of doing traditional work, don't matter a lot in terms of where you place them, but they matter a ton if you're doing disc replacements, depending on the type of disc replacement. Some have keels, they have to be cut. So you have to really position the Caspar pins high and low relative to the disc space you're working on, so you don't create a stress riser or get in your way technically from creating the keel cuts. Or the jigs. Examples would be Protus C, Secure C. Those are example of disc replacements that have big keels that you have to actually cut, have jigs that won't even fit if your Caspar pins are too close to the disc at hand. With segmental plating, this is another example of being very strategic with Caspar pin placement. You will generally tend, with Caspar pins and segmental plating, they want to, let's go from 3 to 5. So we're going to have a Caspar pin here, and we're going to put a Caspar pin here. And then before we do anything with the next level, we're going to have placed the cage and a plate. So if this middle pin at C4 interferes with you placing your plate at C3-4, you'll have to take it out and then reposition it, and you start creating stress risers or injury to the vertebral body. So you want to avoid that by, when you're doing a multi-level segmental plating, putting the intervening pin close to the caudal end plate of the next level. I'm sorry, the disc space of the next level you're going to do. Okay? And that way you get that plate in without any trouble. And if you do, let's say you're going to do 3 to 6, once you've used this pin to do your discectomy, so that pin's at C4, right? You're not going to need it for C5-6. You can take that out so that the cephalad pins or Caspars can go bye-bye as you're putting your plate and cage, and you don't need it anymore. But the caudal one, you have to be very sensitive to positioning.
How often are you changing the angle at which you're putting the Caspar pins to kind of give you more of a doses?
Much less now. I mean, especially with multi-levels, you're more sensitive to just having it strategically positioned, to be honest. So they actually are placed a little more like you will for a disc replacement. In the old days, we would put the pins in essentially a little bit divergent. Exactly. And then as you distract, maybe create lordosis. The reality is, if you do the discectomy and the release and the trials and the cages now, we try to use typically more lordized cages than we used to, tends to be less of an issue than I think when we were using neutral allografts and things like that.
A quick question.
Yeah, go ahead.
So, and it makes sense about the intervening pin. You want to at the more like caudal end of the disc of the end plate there when you hop it over.
Yeah.
Or when you place the plate at, let's say, the level caudal to the most cranial level, does that ever get in the way of like the cranial aspect of that intervening?
Does the caudal, the head above your disc space?
Yeah. Has that ever happened?
It does.
Okay.
But it's okay to take it out then.
At that point?
Yeah. Because you've used it to do your discectomy, your release, and your trialing. That it won't be in the way. It's only with the plate application that it gets in the way. But by that point,
you don't need to like replace
you don't
it or
need
anything at that point. Okay.
It served its purpose. Decompressions, typically fairly similar, I think, for most people. There are a couple nuances to it, and I talked about one, use of traction. Cranial traction can be helpful. Caspar pins in softer bone can just plow through the bone. So you have to be very careful about how much force application that you utilize. My chosen method of getting a release and essentially offloading the Caspar pins or traction is to get a Kerrison into the uncus. And you see a nice example of an arthritic uncus. So I'll actually get that Kerrison up in here and rotate it 90 degrees to drive the heel into this bone you're going to take anyway. Basically, meaning that if that bone is in any way injured, dented, whatever, doesn't matter because you're going to be burn it out. But if you use that move, then you create this release of the disc space on either side. Then as you apply Caspar distraction, it's less forceful and you can still create
significant. Are you just fitting that out, or you're doing like a full oncolectomy basically?
That gets to the decompression part. This is actually just to get, let's say you have a collapsed level. How do you get distraction to work? You could burn it all out, but then you destroy bone you may need.
Got it.
You can use trials, small trials to try to wedge it open. That's reasonable. That can be uncomfortable if you still have some material inside. You might push that back. So when you have a really collapsed level, you have to try to separate it in some way. This is using a 1.5 or 2 millimeter Kerrison that literally kind of finagle your way into that tight spot.
Yeah.
And as you rotate it, it'll drive the bones apart.
And when you do that, you do adjust the Caspar pins.
Yeah. So you'll see that move. it's impractical to have a distractor like you see on the right
Mhm.
in a collapsed spot. You're not gonna be able to get anything. It's gonna be a millimeter or two space to work your way into. Once you get it open a little bit, then you can start using curettes and burrs and things like that. Um, and you want to do generally as thorough decompression as you get. Sometimes that means a full uncinate removal. Sometimes it's just undercutting. I tend not to remove the entire thing, but pretty wide. And as you prepare for that, for all of this, you want to really scrutinize the vascularity, which means looking at the pre-op verts. Here are examples of aberrant verts. You need to know this kind of stuff, whether you're doing a corpectomy or an ACDF, because those verts can swing into the foramen substantially. They can swing into the bone, as you see in that middle portion or on the diagram on the left. And you can see here this unusual position that if you didn't know ahead of time, you could injure coming into the foramen with your kerosene. So really scrutinize the vascularity at the level you're working. And that includes, I will take a ruler intraoperatively, knowing what my vert to vert distance is, and then cutting a piece of ruler and prescribing for myself how wide I can be safely. And then I'll take it out that wide intraoperatively. So I can get the biggest cage with perspective that can be achieved or that is available.
Hey Bob, what do you use?
Yeah.
Do you use like a nerve hook or something to stick out laterally and be like, all right, I feel something. Do you feel for the pedicle? Like, how do you, I know the ruler trick, but like, how do you say, okay, you know what, I'm far enough out on this side?
Yeah, exactly. So I'll use the small curved curette, fill the pedicle, and know that I'm out to the mid portion and lateral aspect of the caudal pedicle. So I would say it's a combination of that as well as feeling that it's free with the same instrument laterally. The caudal for the pedicle, and lateral just to feel freedom from both resection and distraction.
So you take down the oxidate, is that what you're gonna do with this?
I don't usually, in most cases, take it all the way down, but I get pretty close. Pretty close, yeah. And scrutinizing the pre-op imaging is important because sometimes people have they'll have overgrown spondylotic disc bites that extend way out here. And so you really have to get far out, try to clear it out. Sometimes it's a combination of the facet and the disc fights, but you have to be much more aggressive. And that's where, to Kevin's point, you may have to take all of the, yeah. And if you do that, you generally want to dissect down laterally here and get a pen fill in there to protect the vert. Don't just do it blind. All right, I kind of talked about this already. So intervertebral options, there's many, but the general principles from my perspective that I would lean towards would be maximize your width. It's very rare to have a disc space that you can't use more width than they have available. So don't skimp on that. The surface area is important for prevention of subsidence. I mean, so segmental alignment. You have to be sensitive to depth. Some small folks have 12, 13 millimeter depths, and that's a little rare, but 14 is not unusual. So don't say, well, I want to go 22 wide, but they only come in 15 deep, and then push yourself into the canal. So be sensitive to the depth, and then focus on your segmental alignment. Try to normalize it to the degree you can, knowing that you probably will not get as much as the cage provides for. So in other words, a 10-degree cage may not give you 10 degrees, but it'll give you more than 7 degrees well, or more than a neutral cage. In terms of what kind of cage, there's a ton of different cages and options, from allograft and autograft to titanium and PEEK options. You guys will learn a lot about that this year. And there's probably some variance in capability biologically, but we're still working a lot of that science out. The bottom line is there's a ton of options. None of them's right or wrong, probably, except for smooth PEEK and block titanium. I would not use either one of those. There's clear enough data representing they don't work well biologically or from a subsidence perspective. And then plating. I mentioned this before a bit about segmental and long plates, but in terms of positioning, get your plates away from the other levels. You want to prevent heterotopic bone formation and adjacent disease that may be related to overriding plates. And then screw length is super important. This is a paper that represented the importance of having screws that achieve more than 3/4 of the vertebral body, dimension A to P. Now, these were standard plates, segmental plates, some of the angled screws. Not sure we have as good a handle, but I still try to go 75% even with those just based on this data. And then as you're putting plates in, whether it's segmental or long, tighten the upper screws first. You can put them all in, but don't tighten the bottom ones first, and then try to tighten the top ones, because you, if anything, want to have the cuff-led aspect of the plate well seated, so you don't have a lead goose. Okay. Yeah.
If the plates right up to this space, does it have higher adjacent? Yes. This is good.
Both top and bottom. It's that 5 millimeter number. Now, the reality is that's them looking at it after the fact, that when you use variable screws, it's subsidence, your plate can migrate there, and it creates the same problem. So staying as far away as you can probably allows a little bit of settling without encroaching.
I'd like to look at that again, because I challenge absolute numbers like that.
Yeah.
Because,
Oh yeah,
right? So you take someone's vertebral body that's small, like a
yeah.
small Asian lady, right? Versus the Nordic 6'9" dude, right? That you can do it on too. There's got to be a more of a ratio rather than a number. I think.
Yeah, I don't disagree with that. So in terms of long and single plating, these are examples of both. And so you can accomplish your goal regardless of what you use, but there are circumstances where you might want to be more thoughtful about long plating, deformities like this, and spondies. If you have a spondee, generally speaking, they're translationally unstable, and you may even have to consider tying up an additional level to get mechanical fortitude. And I've lived through this. Stephen's lived through this. And it doesn't have anything necessarily to do with whether it's a traditional plate or segmental plate. It's just more about mechanical advantage. You only have 2 points so that plate can cantilever with that translational force behind a spondee.
So in this case, how many levels would you have done in this view? All the way down to what is that, 5, 6, 7? 2, 3.
Which one? On this one?
Yeah.
You want me to answer that, or you guys want to answer? You have two options there, and then neither, I would say, wrong or right. You could go to
you guys gotta say something.
yeah.
Probably have to front back, I think.
You could. It's an absolutely reasonable choice.
Yeah, I'd probably
Levels?
You'd add a level or do a front back at the same level.
Yeah, it'd be hard to do a single level posterior. I'd probably want to go one level below. In addition, probably want to do 4 to 6 front back.
You could, but I would say you're either doing 2 levels in the front, so your plate has mechanical advantage, or single level front back.
I'd probably do a single level front back.
Yeah, and I don't have an answer to that. Nobody's ever studied that, but I can tell you those fail frequently until we have a better mechanical solution.
It's looking at me. I have one on my board.
No, I had it happen to me. I've had it happen to me.
It's happened to all of us, dude.
Yeah.
No, in hindsight, I'd do
Yeah. It's a failure of our armamentarium. But the point is, when you see those, when you see somebody who's got a dynamic spondee in clinic and you say, oh, ACDF, think ahead. Don't think, oh, this is going to behave just like every spondee. You have to think of it just like you think of a 5-1 A-lift in a spondee. Standalones don't work, or they don't work reliably. So those, you put screws in, right? Anyway, that's all I got. Any questions about ACDF.
I'm wondering what your thoughts are about, like say it's a single level case, when you put screws that are perfectly parallel to the vertebral bodies versus, a lot of people in my list to put these angles.
Uh-huh.
I'm not sure which one is better mechanically, or if there's a difference.
Yeah, I don't think we have the answer to whether there's better or worse between those two. The angle situation is a bit of a byproduct of trying to keep the plate away from the other levels.
Okay.
That makes sense. Because the only way you can get them straight in is to have a plate that's sitting fairly high on the vertebral body. So back to Greg's point, if you've got a small lady with a 6 millimeter body height, and you've got a plate with an eyelet that requires 3 or 4 millimeters of body for a straight screw, then you're by definition going to be within a couple of millimeters. That's disc space.
Especially if it's a long plate, it's going to subside and start to creep down. So you really want to be flush.
But if you're, let's say you were going to do a 2-level on this right-sided case, 2-level to try to force a reduction and maintain it. In that situation, do you want angled screws or straight screws?
Straight screws.
Right. Because you want your translational force to be in line with the vector of reduction. The bottom of screws, maybe not, that's less relevant, but the ones right around that disc space you're working on.
Right.
And then sequentially, how would you do that? How would you apply your implants? Granted, cage goes in, but after the cage, you're going to put your plate along, say a 2-level plate. How are you going to perform the operation at that point? It's just AO principles.
I gotta use the plate to apply a force to reduce it. So I work from, I guess in this situation, then you would probably fix your more cephalad screws, and then you would go down and then
Exactly.
reduce that to the more posterior vertebral bodies. Like going out. Yeah.
Very importantly, in most ACDFs, you're going to kind of put the screws in and then go around the horn and final tighten them a bit, top first. But in this case, you're going to fully deploy the cephalad screws, so your plate literally rocks up relative to these bottom bodies. It'll want to do this. So you want to sit like that. So you want these to be seated fully, final tightened, and then you're going to put all 4 screws in the bottom at the same time and sequentially tighten those in and try to bring those 2 bottom vertebral bodies, and then switch. Sometimes you have to switch screws out to shorter screws because you have to start long just to get to the.
So the funny thing is, I'll frequently do the opposite, which is I put the 4 in the bottom and I let the plate push. Yeah. It's just 2 ways to skin the sink. But I think the bottom line is and you can do either way because you have flexibility above and below.
Yeah.
Different than a fracture model, right? Where you only have 2 bones that are broken, you're trying to reduce, right? So there you have other anatomic considerations. But
You guys use the kind of like the plate inner body kind of combos, and then would that be something you could also use kind of segmentally reduce as well if you had something like this, or would you still want to rely on a more like robust plate for that?
Yeah, if you're trying to reduce, it's very hard to do that without a longer plate.
Yeah,
you just don't have the mechanical advantage.
Okay.
The plate kick.
Yeah.
If it's a small plate, it'll cantilever.
Hypothetically, if you were going to do a 1-level front back on this one, I know sometimes, at least I've seen for A-lifts, let's say 5-1 or 4-5 or like a spondy, they'll not put a screw at the cranial body just so that they can reduce it from the back. Is that something similar to consider in this case if you were to do that, or you think it's flexible enough where you could fix your implants?
Usually you can.
I've made that mistake.
Yeah.
I made that mistake. I don't know. I should have cased a conference where I did just that, and it failed. And we all agreed that I probably should have put screws in the front.
Yeah,
you're going to get most of the reduction mostly from the inner body, and you know what I mean. I don't know, Bob. What were you going to say?
I was just going to say usually the challenge is maintaining it. If you can get the reduction well enough accomplished in the front, but the implants can't maintain it.
Right.
So you're going to the back to hold it rather than reduce it.
Okay.
That could be different in the lumbar spine. There you may do that sort of fixation to one body and then drag it back and reduce it fully.
Okay.
But in the lumbar spine, you have much more bone screw
Yeah.
ability. Lateral masses are not going to give you fortitude enough to be applying a lot of load.
Yeah, you lose bilateral mass and now you're ST2, right?
Mm-hmm.
I will say, I think most of us are, and I think Kevin, I've talked to you about this too, like are using more cervical pedicle screws now when we have navigation. So like, it's definitely a more common thing to do. So you can look at your anatomy ahead of time too. Although I would say a lot of these patients that have these like crazy spondies, they have like crappy dysmorphic pedicles, and like you're like, oh, I'm not risking that. But just be aware, like that's another tool. If you look at it, like, ooh, this patient's giving me some pedicles that could be good.
And usually the bad actors are upper cervical.
Yeah.
3, 4, 4, 5, where pedicles are not typically useful.
Yeah, the one that they're referring to in the line, they had a like 5 mm mobile spondy, 3, 4. I did an ACDF. Perfect. I did great. 2 weeks later came in. It's like back to where it was before. It was just too loose.
All right, you guys ready to go to cases? Any other questions?